surgery involves the complete removal of the prostate gland and the attached seminal vesicle, which is a storage sac for semen. It also involves reconnecting the bladder to the urethra. This operation can be done by open techniques or robotic techniques or laparoscopic techniques. The open technique is the technique which has been around for the longest. I'm very fortunate to have a very large experience in open surgery. In fact, over 3,000 cases, which is in fact the largest in the Southern Hemisphere. In this time, it's been possible to improve the technique to get excellent outcomes in terms of cure, continence, and potency, and minimal complications. It involves a small incision in the lower abdomen, usually a 3 or 4 day stay in hospital, and also a catheterisation period of a total of 7 days. That is, the 3 to 4 days in hospital and another 3 to 4 days. It is not an overly painful procedure and is tolerated very, very well, most people being up and about within 48 hours. The success rate in my own hands has been excellent, with a very low positive margin rate, and in fact we've published some of the best outcomes of this internationally over the last 10 to 20 years. As I said, the aim of the surgery is to cure the cancer and to minimise the risk of incontinence and impotence. Every cancer is different, and every cancer needs to be treated differently. With patients with intermediate and high-risk cancers of the prostate, they also require a dissection of the lymph glands, and this is something that I've been offering all my patients as standard therapy for over a decade, and this is done with the extended technique, which has now been shown to improve the chance of curing these high-risk cancers. So, in essence, we remove the prostate, the seminal vesicle, we reconnect the bladder to the urethra, and we have people in and out of hospital within 3 or 4 days. Part of the operation is also to remove the lymph glands, and if you have spread to the lymph glands, and if that spread is minimal, there is early evidence that we can still potentially cure that situation. So I'm often asked, how do I decide which patients I'm going to offer open surgery or robot-assisted surgery to? Clearly, my patients who have robotic surgery have a quicker recovery, less blood loss, and possibly earlier return of functional urinary control and sexual function. Having said that, these become less of an issue with very, very high-grade cancers where the key aim is to make sure we cure the cancer. In the latter, that is to say in the very high-grade ones, I often offer open surgery based on my experience and results to maximise the cure rate and to minimise side effects.